All right, welcome everybody. Thank you for joining us for today's webinar, FQHC Specific Strategies for Using Data to Increase Cash Collections. My name is Amanda and I'm the Marketing Business Development Manager here at Revenue Health. Before we get started, I'd like to point out some housekeeping. Please make sure your lines are muted, and if you have any questions during the presentation, please type them in the chat section and I'll share all questions at the end. We will also be recording the webinar and sharing out the presentation at the conclusion of the event. Our presenter today is Jeffrey DILIDDO, the CEO at Revenue Health. Jeffrey brings 2 decades of billing and revenue cycle management systems experience, serving for over 5 years as a Director of Information Systems for PMG Inc., an RCM firm focused on helping community health centers achieve their financial goals. While at PMG, Jeffrey helped pioneer new software and technology to improve the billing and RCM process. Most recently, Jeffrey has taken the lead at PMG's new technology wing, Revenue Health Systems, giving CHCs access to the best-of-breed billing and revenue cycle software solutions. So without further ado, I will turn the presentation over to Jeffrey.
Hi, thanks, Amanda. You can hear me okay?
Yes, we can hear you.
Great. Well, thanks everybody for joining today. Good morning and good afternoon, based on where you are. Just a little bit about PMG and Revenue Health, just quickly to let you know who we are and what our perspective is if you're not familiar with us. PMG is a fully managed outsourced revenue cycle company with separate outsourced revenue cycle management, credentialing, and software services arms, and Revenue Health is the software arm. PMG, about 15 years ago, made a decision to focus solely on FQHCs and CHCs and has been developing strategies for providing best-in-class billing services for the CHC market only. They don't do business in any other specialty. While I was at PMG and with other PMG team members, there was actually a lot of people involved. We developed best-in-breed RCM tools to solve problems to do with working on many billing systems such as NEXTGEN and ECW and Allscripts and Athena. And we were frustrated by some of the same things that our clients were frustrated with. At the same time, our clients were thirsty for reporting that our account managers provide at the end of every month. So we developed software for our team to use internally to manage workflow and perform denial analytics. And that allows our operations management and our account managing team to manage both the in-house team, but also report back to the clients where there's opportunities for improvement on both sides. A couple years ago, PMG, after some sort of meeting people in the market where outsourcing wasn't the right solution for them, or they weren't prepared for that solution, started to get some requests for technology to get access to some of the technology that PMG was using, and that's sort of where Revenue Health Systems came from. So for clients who are not PMG revenue cycle clients, or for community health centers who are not PMG revenue cycle clients, there is an option to get access to some of the workflow tools that PMG has access to. And we've built cloud-based medical denial management software and analytics automation software. We also help people convert paper EOBs. And all of our software development is FQHC focused primarily. We do some work outside of the CHC market, but all of our development sort of starts with those challenges that are very specific to FQHCs. And we're working with pretty much every system out there, whether it be Athena, GE, NEXTGEN, pretty much all of them we're working with at this time. So to briefly talk to you about the agenda today, one note I do want to say is that our focus is going to be our focus and from our perspective. So a lot of the screenshots that we're going to share will be from our system. It's our opportunity to share with you what we do, but it's also an opportunity to possibly give you another way to look at it. So if you have questions, feel free to send a chat to the host, and we'll try to answer questions as we go. If there's something really relevant, Amanda, feel free to butt in with a question, because we would love to make this a conversation as much as we can. So we'd like to talk to you a little bit about what data trends we're seeing, or what we're seeing in healthcare data. We want to talk to you about a couple new performance indicators that maybe you hadn't thought about before, and how you use those to measure your success. And then I want to introduce you to the key data sources. Like, what is this data? What are we talking about? And how would you get access to the data? And then we're going to talk about a two-pronged approach. And really, to be successful, denial management and accounts receivable management starts with two areas. The first area is to sort of stop the bleeding, to stop denials from happening at the source. So denial source identification is critical. You need to stop the inflow of claims to your accounts receivable, because if you're overwhelmed, or you have staffing issues, or you have some of the issues that we've learned about out in the CHC market, the AR will just end up growing and growing. And then once you do capture everything, on the other side, you want a strong workflow management process, which not only captures all the work, but only the actionable work, and importantly, make sure that nothing ever gets lost. So we'll take a look at a couple different case studies for denial source identification and workflow management. And then we'll finish with summary and questions. Again, we love questions. We'd love to hear about your challenges. So we'll go from there. So talking about data trends. So Seagate is a company out there. If you don't know who they are, they're a technology company. They make most of the disk drives that are in the major servers out there. So they're a major data hosting company, one of the largest in the world. And they did a study where they said that healthcare by far over every industry is growing in its use, in just the amount of computer disk space it's buying to host data. And it's growing at least 13% faster than every other industry. And the expectation is that hypercritical data, which is kind of an interesting word, is expected to grow more than double every other year. So on average, 47%. And the interesting thing about healthcare data, and if you're doing a lot of trolling around LinkedIn, or reading healthcare IT news, or reading articles from Health Insights, you're hearing a lot about machine learning and artificial intelligence. But my experience has been in the market, that a lot of that, and a lot of the systems development is focused on the clinical side. I've seen a lot of large hospitals full of very bright people spend a lot of money on systems for the clinical side alone, completely forgetting about their revenue cycle. And so our focus is solely on the revenue cycle. And so that's what we're going to talk about today, what data is out there and what's available to use for us to use. So the whole revenue cycle benefits from data. If you've gone to any trainings that PMG has done, whether you've seen Ray or Robert or Caroline speak, either at a NAC event or a PCA event, you'll hear us talk a lot about this triangle of communication between them. The graphic on the right, you can see providers, billing, and front desk. And we've talked about trying to eliminate this drama circle where the providers and executives and board are dissatisfied or are not seeing the cash that they expect. They put a lot of pressure on billing sort of pointing their fingers back at the front desk and back at the providers, and sort of there's blame to go around. And one of our strategies has been to create partnerships with practices and partnerships inside practices, so people have the data that they need to make improvements. And so some of the ways that data supports those relationships and those partnerships are, number one, it creates bidirectional visibility and accountability. So you get everybody looking at the same data at the same time, and you get executives and board members feeling like they know what's going on, and you have directors and managers showing those people the data that they can feel confident in presenting, and that they're telling their story and being heard. Data can also be used to present answers instead of more questions. If you structure your reports in such a way and structure the data in such a way, you can actually bring out the data that you're looking for and get answers right away and get moving. And that helps you eliminate wasted time, data can help you automate your processes, whether it's through auto posting, whether it's through month-end functions, and it's essential in carving your work down to just actionable data. And you can give your billing members, your team members, instant feedback to their successes. We're going to talk a little bit more about that later on. So, you know, in community health, getting the data is not easy. You know, most of the CHC-focused billing systems, again, the GEs, the NEXTGENs, the Allscripts, the ECWs, the systems that have put time into developing solutions that work for community health, the reporting can be very, very complex. It can be thorough. They might provide you with a lot of data, but a lot of times the reporting is done in silos. So you might get your AR detail, but your managed accounts receivable, your month-end aging is not married against, well, what's sitting on the aging by denial? How much of it is rejections? You may be able to get productivity detail, how many patient-provider encounters are happening, but that's not weighed against payment detail or resolution rates. So, you know, in some of the systems, you know, we had a phrase that was, you got to run 10 reports to get one, and you'd have to run 10 different reports, you know, do all these fancy Excel VLOOKUPs if you were lucky enough to have somebody to get some really meaningful data at the end of the month. And some of your data is captured on paper. So if you're handling paper at all, you're dependent on data entry, the accuracy of data entry, and also the completeness of your data entry. So it's not, getting the data is not easy. You need to have some expertise on hand to get there. And there's usually three scenarios that we see out in the market. The first one is you either do your billing in-house or you've outsourced to a firm like PMG and you're very, very happy with the results, either your internal team or that you're getting from your RCM vendor. Or you've outsourced to an RCM firm and the results aren't where you think they should be, but you're not sure why, and you're not sure you feel a whole lot of transparency or visibility. Or you're doing your billing in-house, and again, cash isn't where you think it should be, but you lack the data that you need. And that's really what we're going to be talking about today, is practices who are doing their own billing where outsourcing is either not the right solution for them or it's just not something that they're ready to decide on. So for those folks, we want to present some information to you about where do you go to get the data. So the last thing I'll talk about in summary are some new key performance indicators. And traditional key performance indicators, month-end indicators for revenue cycle management and billing were cash collections. You know, I mean, cash is everything. All the other metrics don't matter if cash isn't supporting the business operation of seeing patients. But also the days in AR. So on average, how long is it taking you to get your claims paid? Is that 45 days, 90 days, 120 days? And then again, in terms of the accounts receivable, it's critical to know what % of your accounts receivable is over 90 days, and is that over 90-day percentage growing? You know, if you're over 90 days, is much over 18 to 20%, you know, that means that claims are flowing in there, and prospectively, they're not coming out in terms of payments, but they might be coming out in terms of write-offs. Excuse me. And your net collection rate. So your net collection rate is a look at your payments and what you expect. So if you calculate all your contractual adjustments from your payers, all of your expected write-offs, your net collection rate calculates what did you expect to get paid and what percentage of what you expected to get paid. Whereas your gross collection rate is just, I billed out this much, I got this much, it's this % of what I billed out. But really with all of the collection rates in there, the net collection rate is really what most revenue cycle management firms, and especially PMG, will be reporting to you. Here's what we expected you to collect. And it varies. It varies from state to state. And it varies from operation to operation. So one of the questions I get asked a lot is, what should my net collection rate be? And I'll tell folks, well, if you're a privately freestanding primary care practice in a high economic area, it should be 99%. But if you're a community health center dealing with massive state-based Medicaid and Medicaid managed care issues, your net collection rate is going to suffer a little bit more than that. So there's some new metrics that as a company at PMG, but also as Revenue Health and our technology that we're working to offer out to the market now are things such as the average payment per encounter, or we call it a blended encounter rate, and your denial rate. And there's two ways to look at average payment per encounter. The first is just your blended encounter rate, which takes in a time period all of the claims that you billed, and you divide that into how much you were paid, and that tells you on average what you're getting paid per claim. And that takes into account claims that were paid, claims that were not paid, claims that are pending. And then you just take a look at your paid claims, your average payment per paid encounter, and that's going to get you a little bit closer to your net collection rate. And your average payment per paid encounter, not what the average state blended encounter rate, but in your health center, when you get paid across all of your third-party payers, what are you getting paid? And when you weigh the two of those together, if there's a gap, then this presentation is going to talk to you about filling that gap. And typically, the gap is in your denial rate and rejections. So with that, I'll give you a little diagram here. This particular report lists over a 6-month period a number of claim instances, so how many instances of every EOB that was received either electronically or paper, the number of unique encounters, which I just put a red indicator around. And so this practice in this time period is doing about 18,000 unique patient-provider encounters that they billed for. These wouldn't include unbilled activity. And then we take a look at their payments for that time period. And if we divide the one into the other, if we divide payments by encounters, you end up with, on average, $115 across that 6-month period. Now, this health center's in the Midwest, the northern section of the Midwest. And when we looked at their paid claims, they were collecting $140 for every claim that was paid. Even if it had been denied once, if it eventually got paid, they were collecting $140. So on average, they're collecting $25 less per claim than they could be when they were getting paid. And so that gap, if you look at a practice like this, they had an extremely high denial rate. 27% is very high, and it's not uncommon. We've seen denial rates very, very low into the single digits, but most of the denial rates we see are between 10 and 15%. But some of our clients come in the 20s, and this particular client was in the high 20s. So the denial rate cost alone, if you look at some statistics from MGMA and also from HIMSS, MGMA is the Medical Group Management Association. They've done some studies that show on average it costs about $25 per claim to resolve. So this practice, doing in excess of 36,000 claims a year and 27% of them getting denied at $25 per claim is $247,000 a year in cost. That's in human time to work things that maybe they didn't need to work. So goal number one, denial source identification. Let's reduce the workload. If your folks are saying to you, or if you're the one working the denials and you've got more denials than you can handle, more AR than you can handle, then the first thing you have to work on is the incoming denials. And there's that 27%. So of the total encounters, what percentage of those were denied? And those are the ones that the team has to handle. The revenue opportunity there, if you, again, annualize their claims over a year, so over 36,000, and you coincidentally, the variance in what they could be getting paid versus what they are getting paid is $25, you're looking at almost $1 million. So together, this is over $1 million in additional revenue or reduced cost for a practice that's seeing 36 to 40,000 patients, which is, not one of the largest health centers. There's health centers out there doing 300,000-400,000 visits a year. So the impact gets monumentally larger. So when you're looking at all of your key performance indicators, this is data that you can pull out of your practice management system. The number of unique encounters, and most of you are probably capturing that. You're billed and allowed, you're paid. So notice I don't have anything about contractual adjustments or write-offs in here. It's just very, very brass tacks. What did you get paid? And so that's sort of one of the new things that we in the FQHC market are trying to bring. So what data do you need to close that $25 gap on every claim between the $140 and the $115? Before I move on, Amanda, I just wanted to pause and see if anybody had any questions about any of these calculations or KPIs on screen. I know sometimes I get going a little fast, and I just wanted to check in.
Sure, yep. We have no questions at this time.
Perfect. All right. So what are the data sources? What can you do to close this $25 gap, or whatever the gap might be in your practice? It could be $2. So the first thing that's important to understand is some of the EDI. If you're not intimately involved with the billing process every day, you have an EMR and a practice management system, and you may be on an eClinicalWorks EMR and an Allscripts practice management system. We've seen it. They could be made by the same system, but there's a process of getting your charges out of your EMR into your PM. There's a process at the front desk to get registration and demographic data into the PM. And then there's a process in the PM of getting claims out to your clearinghouse and eventually out to the payer. So those flow out in what are called 837 files. The standard data interchange is called an 837. I'll get into that in more detail. So there's a ton of data in those files. And then on the way back, electronically, your payers will return EOBs, paper EOBs, or they'll return HIPAA 835 files. And the 835 files we're going to spend a lot of time focusing today, but it's not the only place you need to be looking. So if you're not getting paid, there's a couple different reasons. One, you may not have claims going out the door, and that's a problem on its own. If you have credentialing denials, a particular provider that's not set up with a payer and you're holding those claims, those are sitting in your system. You need to have a really, really great way of queuing those up and tracking them. But once a claim file goes out the door, the payer will check it for structure and content. It'll make sure that it meets all of their internal requirements. So not just is everything in the right place in the file, but does the insurance ID match what their accepted insurance IDs are? And if the structure of the file doesn't match their standard, which has to be within the HIPAA 837 standard, they'll reject the claim. And that all happens at your clearinghouse. So rejected claims don't exist to the payer. You can call them all day, and they don't know that they've got them because they rejected them, and they sent you a detailed report on what came back. Those detailed reports are typically available in your clearinghouse, and you can track all of that work through the clearinghouse. But it's critical to have a tracking mechanism inside the billing department and something that you report on at month end as to how many claims got rejected, how many were resolved, and how many were pending, and that you're tracking those over time. Additionally, just like your denials, where we're going to spend a little bit more time focusing, the payers will tell you why they are rejecting things. If they're rejecting them for content, whether it be eligibility issues, whatever those issues might be, they will come back and they will tell you. So when I'm showing you some of the reports on screen that you're seeing around denials, keep in mind that someone in your office, or it could be you, should be reporting how much went out to the clearinghouse that didn't get accepted and what's left to work. That stuff turns into filing limit write-offs before you can even notice that it's going to happen. With 90-day filing limits, if someone isn't on top of those can create very high-risk claims. There's also some black holes out there, I'll call them, return to providers reports, RTP reports. If you're lucky enough, I guess, to work in the state of Illinois, you deal with sort of black hole reports. So these are just things that they say, we're just returning these claims to you. We're not even going to look at them. They don't give you any 835, any EOB. And so if you're sending claims to Medicare, you should be talking to your team about, do they have a handle on what's on the RTP reports, and do they have a way to track those? So rejection is not a denial. A denial is an adjudicated claim that the payer made a decision on. A rejection is a claim the payer does not know about. So the lingo, 837s versus 835s. So outbound claims are called 837s. In the old days, or on paper, you'd send a UB or a HCFA or an ADA, but now those are called 837I or P or D. And then the inbound remittance files, the electronic standard HIPAA remittance file, is called an 835, and there's only one form of those. There's not an institutional or dental professional. There's one kind of 835 out there. And the key thing in those remittance files are the adjustment and the REMARK codes. Those remittance files tell you everything your EOB would tell you with maybe a little less detail, which I'll talk about in just a minute. It will also talk to you about any payments, denials, reversals. Those things are all captured in those remittance files. So if you're not enrolled for electronic remittance, even if you think you're not prepared to auto-post them into your system, you should get enrolled in those so you can be prepared when you are. So paper EOBs, billers, again, been doing this for a couple decades now. Billers love EOBs. They typically have local codes on them. They're typically very, very descriptive. You have sort of everything you need in your hand, but they're expensive. You have to download them, print them. You may have to scan them. You're storing them. There's a lot of expense associated with that. And then, importantly, you have to manually post them all. You cannot auto-post paper EOBs, even if they're scanned. And they're impossible to track. You know, unless you're collecting all of the data off of those EOBs or doing some sort of conversion lift, then you're not going to be able to get to that data. The trade-off with electronic is sometimes the reason codes are too generic. There's only so many reason codes in a standard electronic file. So sometimes you need to spend some time learning about the combination of what those codes mean and how they relate back to the denial. But sometimes they don't have as much specificity as the paper. Denial reporting tends to be procedure line focused when we know at FQHC a lot of our claims go out encounter rate if you live in an encounter rate state. But there can be a huge time saver for the practice with auto posting, and they create an archive. You can get back to them very easily, and that's important. Most of the systems have an ability to parse out or view some of the data in these electronic files in a human readable format. So this becomes something that you can store on your enterprise billing network, or you can go out to your clearinghouse and ask them for a download of them. You know, they're available to you, and if you are auto-posting them into your system, you're probably saving yourself a lot of time. Now, I run into a lot of folks where the way that the 835s come back from the payer, the system isn't quite equipped to handle whether or not it's a wrap claim. They'll come back with certain adjustment codes which look like payments, but they're actually denials. And so there's a critical amount of work that can be done to set up your system to handle those things, and we'll talk about that in just a minute. So when I was talking about adjustment and REMARK codes, if you're not aware, there's a website out there. When we'll send out the deck to anybody who wants it, and the link is right in here to the Washington Publishing Company who produces these lists. But they're typically grouped in codes. So the first code you see there's number one is the deductible amount. At the bottom of the screen, you can see one that says the procedure code is inconsistent with the provider type, right? So when you start to marry these codes with the groups, they start to take on new meaning. PR1 is a deductible amount. That means the payer is saying, listen, I've approved this, but the patient's got a deductible. You should send them the bill. A CO, a contractual obligation, is them saying, listen, according to my policies, I'm not going to pay this. Whereas an OA or a PI many times indicates that there was another payer who made a decision and that this payer is making their decision based on what that original payer had said. So you may get an OA 23 where they said, I'm not paying this outside of your contract. You know, this is covered under another contract. So understanding, going out and finding these, back in the day what I did is I cut and paste all these into an Excel spreadsheet, and I started to make mappings of these codes to the denials by payer so we could start to see what are all the procedure denials, what are all the contractual denials, when is my particular state Medicaid using a code to tell me something's paid, when are they telling me that something's included when it's actually a PPS claim, so it's really never going to get paid anyways outside of the original payment, outside of the original procedure. So starting to collect some of this information, again, the link is in here if you need it, and creating your own mappings is critical. There's the link right there, wpc-edi.com. So if you want to take a screenshot, or again, we'll send this out to folks so you don't have to do that. So if you're going to spend time getting the data, you ought to invest the time into configuring your system for auto posting. And if you're doing that already, fantastic. I spent a lot of my time working for practices. I'm helping them configure auto posting. And I would say 85% was a really great goal to shoot for, even in electronic payers that were really, really great payers and giving us a lot of data that we needed. There was usually about 15% fell out of the bottom, either no provider associated with it, or there were adjustments that we did not want the system automatically taking. But the process you have to go through is to go payer by payer, identifying each remark code and each adjustment code and setting up the business rules. Because if one payer says that something's an included service and they use a code called CO97, the systems by default are designed to adjust those off because they are adjustment codes. But if you adjust them off, they're gone. So in many cases, you want to tell your system not to take that adjustment, and you should err on the side of be a little conservative with that. If it could ever be adjusted, but it was something you needed to work on, you don't want to let the system automatically post that payment and that adjustment for you. Same thing for transfers. You'll need to focus on looking in the dictionaries and identifying which switches determine whether or not a particular balance gets transferred or not. We all don't want illegitimate balances getting transferred to the patient. That just creates headaches for everybody, phone calls, angry patients. So we want to avoid that. So if you're not doing auto posting yet, there's a lot of information out there, and if folks are interested and want to send an email to our learning or our info@revenhealthsystems.com, and we get a bunch of requests, and maybe put together a webinar on how to do that. So now that I know I've got all this denial data and this rejection data, what do I do with it? How do I increase my cash collections? How do I close that $25 gap? And that's where we get into this two-pronged approach. So the first prong is eliminating denials at the source. And denial management matters. We have met a lot of practices that don't do any denial management whatsoever. They just work AR lists. They start at the top of the list and they work to the end of the list, and they cannot get caught up. 30% of the healthcare providers, according to HIMSS, are still using manual claim denial management processes. And again, according to MGMA, this stat's a couple years old now, but the cost to rework a claim is $25. It's probably more like $8 or $10 the first time you touch it. And then every time you touch it and the older it gets, the more expensive it gets. So by the time it gets to be 30, 60, 90 days old, it's probably costing you $30, $40 to work that claim. It takes a lot longer. And another statistic that's out there is that 65% of denials are never reworked, and the payers are counting on it. And, it's an entire system designed around policies where they don't pay their bills. And so there's a level of risk that the payers take on knowing that some of the claims will not get worked. If they didn't have that, this process would be a lot easier, and companies like Revenue Health and PMG wouldn't exist. So that two-pronged approach is eliminate denials at the source and implement workflow management. So stop the bleeding first, and number two, make sure you're managing the denials that you do have in an orderly fashion. So I'm going to run through these pretty quick. But here is the strategy that we employ and that we recommend that you employ to eliminate denials. Number one, identify their source. Pull together as many reports. Go out and learn. If you don't know how to have someone in-house, learn. Google how to do a VLOOKUP. Merge as much data as you can via Excel. Look in your PM report that will give you reports by facility, location, department, service line, whether it be medical, behavioral, dental, provider, and there should be a comma, and then procedure. Make sure you can identify those. I'll show you where we do them, sort of shameless plug of our system, but key to identify where they're coming from, and then isolate actionable claims. An encounter rate denial where the first procedure pays and the rest deny is not the same as a fee-for-service denial. And there's a lot of fee-for-service work happening out at the FQHCs, way more than I think a lot of people really realize. There's a lot of fee-for-service denials that are going unlooked at. So if you're in your billing system, whether it be eClinicalWorks, Epic, a lot of them have work queues that you can develop. So create work queues that isolate especially Medicaid and Medicaid managed care issues. I mean, the vast majority of the patients are going to be Medicaid managed care, and a lot of the folks who have brought us on board are in states that in the last few years have flipped a lot of the patients over to the Medicaid managed care, and it's a mess. They don't know what patients are theirs. They don't know they didn't set their systems up. It's just that transition can be a real mess. So creating work and doing reporting that isolates that business can free you up to see the other things that you're not getting paid for. And start to understand denial scenarios. I was doing some work with a team, and we developed some reports based on electronic remittance, based on electronic remittance codes, and they came back and said, well, I don't know what this means, I need the paper. We said, we're not letting you use the paper. You have to learn what this means from the 835s. And no, I'm going to have to call the payer to find out, was the response that I got. And what we had to train our team to do was to understand in those words above, facility, location, department, procedure, provider, payer, when you take all of those signals, all of those different pieces of a claim, and marry them up with the full list of adjustment codes and full list of remark codes, they start to create unique scenarios. So the more your team can be trained to understand the claim scenarios that end up causing certain types of denial codes, the less dependent they will be on the paper. And it's tough to do. We've been using EOBs for a long time as billers. But if you can do that, then you can start making decisions based on data and not having to call the payer and not having to dig through some paper. So once you've isolated your actionable claims and you've identified the source of those claims, pick the top one. It's not even focus on the top 2 or 3. Pick the top one and engage every single person who can help you eliminate that denial. Get them in the room, front desk, providers. If it's the CFO, see if she'll come down to the meeting. Whoever can help you or who might have a hand in eliminating a denial, get them in the room and working together and create the organizational goal of eliminating that denial. I've looked at 5, 10 million worth of claims, and the top 2 or 3 denials for almost every practice, legitimate denials, not denials they expected to get for one reason or another, but resolvable denials, they're usually 20 to 30% of all the denials combined. A lot of them are front desk registration, but a lot of them aren't. And then create a process for monitoring this work. Every month, create some accountability, report to the CFO, report to the Director of Revenue Cycle, what you're working on, where are you at with that top denial. So this is one of our system screenshots, and you can see here a couple different areas. Number one, we've taken all those denial codes and we mapped them into categories so we can see which categories are the top over time. I can get maybe some percentages, some volumes, but then I can also see where are they happening. Are they happening in a specific location or a specific payer? So we break them down in a number of different ways. And then we isolate actionable claims. So for a particular practice, one of the case study practices we're going to be talking about today, they have one of their managed cares is not being very nice to them. They are not paying claims. They're not adjudicating them with enough information so that they can know what's going on. And so we built them a dashboard which isolates just down on those particular denials so that they can identify it. And this green bar that the big blue arrow is pointing to is all that payer. So when we take that out of the way, they can start to see the other things that they need to work on. So that's what we mean about isolating actionable claims. They still report on this. They can still see if the number's going up. This is still included in their work lists, but they've captured it in a place where it's not in the way of the other things. And then resolve and monitor. These are some credentialing denials from, again, sort of the Midwest. And they had in April of 2018, they had a lot of credentialing denials surrounded around a couple NPIs. They resolved them. They went away. They got back together not that long ago, and noticed that they had come back. They had a different provider come in. It was a different issue. So creating reports, when I talked earlier about reports that give you the answers, if you have a credentialing issue and you open a series of reports that you've created for yourself, a dashboard could be a bunch of Excel spreadsheets with graphs that you use. Ours are automated, but you can do this work for yourself if you've got a little Excel acumen. And so to resolve credentialing dashboards, you need to be asking credentialing questions, and then the data will give you credentialing answers. So who are the payers? What's the biggest payer? What NPIs is it? Is it out of a particular location? Is it a particular NPI, for example? So you don't have to be a billing expert to know that it's a single provider in a single NPI. I can see who the payer is, and I can see, importantly, that when I resolved it, it went away. But every single month, at least every month, they come in here. This data, we update our data every night for them, but they have a schedule of coming back in and looking to make sure. So in December, when that issue came back, they resolved it, snap of the fingers, it was gone. So that's maybe the most important thing, is that you continue to once you've resolved an issue, that you monitor it. But as you resolve the first one, move to the next one. And then again, monitoring denials as a whole. This is a very holistic, high-level view of denials, where you can see the denial rate trending down. And down below, so there not only is the rate of denials that they're getting going down, but down here in the bottom left corner, the volume of denials is going down. So that doesn't mean that they're just working fewer claims. They're getting less of their claims denied. And so they can track and see if they get a big spike in a given month. So down here in the bottom left corner where it says June 2018, they can see what the big spike is. And if they had a big issue with timely filing, they can go to their timely filing dashboard, just like they could have for their credentialing dashboard, and there would be timely filing answers there. So that's where those REMARK codes come in, and marrying up your denial reports with facilities, locations. Over here, they can see, did it come out of a particular location? It was sort of spread out. But multiple perspectives on looking at your data can really empower you. So let's talk about a case study. This is a CHC in the Midwest. They're a GE-CPS client, so Centricity Practice Solutions, and they just didn't feel like they were getting access to critical information. There's a lot of reports in GE, but they were not functional in getting the data that they needed. Their denial rate was in the 20s. They couldn't understand why it was so high. They didn't know what to do about it, and they didn't know where to start. So they also, maybe more importantly, lacked an organized method for working denials. They printed a denial report and they started at the top and they never made it to the bottom of the report. So if the really, really old, really, really expensive denial was at the bottom of the report, they lost that revenue. And their billing staff morale, it suffered. They just thought they were spinning their wheel. The AR was growing. The CFO was not happy. The board was not happy. And there was not a lot of interest from the executive leadership in terms of the details of the revenue billing process. Sometimes I start talking about 837s and 835s, and CEOs' eyes start, glazing over, and they get a little bored with some of the detail. So their key data solutions were to, number one, identify and properly handle fee-for-service versus encounter rate payers, especially in a primary, secondary payer situation. They were handling a lot of fee-for-service claims. They were handling a lot of claims that they thought were fee-for-service that were actually encounter rate that they didn't need to be looking at. And again, determining the true actionability of those encounter rate remittances. And then they worked to identify, this is the first prong, they identified and compartmentalized where those denials were coming from. So again, they focused their effort. One of the things that they could control, were their registration denials. So that's where they focused their effort. And they put together some dashboards that really focused on, number one, trending the registration denials, registration and patient eligibility, identifying what problems they were having, but importantly, where they were having them. These are their facilities over here. They went out and did training at each of these facilities to make sure people knew what they were doing. And just look what the numbers do month over month in registration denials. So if you want your denial rate to come down, 5–10%, that's how you do it. You start to chisel what you can control, and that's that downward number there. Additionally, they created workflow systems where they could isolate those non-actionable G-code claims. They were PPS claims. They shouldn't have been showing up as denials. So they isolated those, and that left them on the bottom a lot of really healthy, workable, manageable lists of denials that they could get after, and everything was captured. So the outcome was they reduced their denial rate by over 10%. Their blended encounter rate went up by over 11%, and they're doing well over 140,000 encounters, and that equated to well over $1.5 million in prospective cash that they're going to be collecting if you multiply that. And their re-denial rates, the rate of denials coming back in the door is down just to 2%. And so the CFO was beaming about this, that he finally had data that they could use both vertically and both at the top of the organization chart all the way through the billing team, and that they could create an overall goal for them to get a clean claim out the door. So their re-denial rate was, it's funny, you'd think the cash would make them the happiest, but their re-denial rate was something they were really, really proud of. And it was an organizational effort. It took their GE system manager, the CFO, the revenue cycle director, and their billers are enthused. They feel good. They're collecting cash. They're, on some Fridays getting together and celebrating their work. So people are happy, and that's really making them more productive. So the second prong here is workflow management. And I'm going to run through this not too quickly, but I want to leave us 5–10 minutes for questions at the end. So capture data over time, isolate just the actionable claims, and then put processes in place to go back and see what your team did. Whether, again, if it's a spreadsheet, whether it's a list that, Jeff touched 100 claims and here's what happened to those 100 claims. Periodically go back and look, even if you do it in a small audit standpoint. The point is to empower your team members. John Gordon wrote a book called The Energy Bus, and it starts with a line he starts with, a phrase, catch people doing things right. We're always catching people doing things wrong, but denial management can be about identifying what people are doing right. So in this case, if they're tracking particular work lists over time, are those work lists getting lighter or heavier? Are there more claims coming out in the door than they're working? And in their case, no, they're working more claims, the red bar on the right, than are coming in the door, which is the red bar on the left, or the blue bar on the left. And that's why that number is going down. They also track their team performance. They can see who's touching how many claims. They can see that two people are touching about the same number of claims. One is 420, one's 440. And the person handling more claims has a much higher resolution rate. But they can identify a person who's handling thousands of claims, and the majority of those claims are getting paid. So what they do is they focus on what's different about that person from everybody else. Did they just have the best payer? Do the other people have the state-based Medicaid managed care that never pays their bills? Or is this person doing something differently? And they're celebrating this person and trying to make it so that everybody can have an opportunity to see what types of actions are they taking, what's working and what isn't. Because again, trying to get away from start at the top of the list, working our way down to the bottom, unintelligently, just trying to get through the work every day. So a NEXTGEN practice in the Southwest, they were concerned that their cash collections were not matching clinic productivity, and the director of revenue cycle was frustrated because she didn't have the data. She needed to explain what was going on. She could see what was happening, but she needed data to give back to the CFO, and they were lacking visibility, and pulling meaningful data was very, very difficult, and they just ended up with an overwhelming number of claims. So their key goals were, again, isolating the actionable claims, ensuring that all the claims are accounted for, and then they've created a lot of internal processes around this. So this is just one piece of the denial of the revenue cycle, this denial management portion, but it stemmed off into processes in different areas of the organization, which they own and have, frankly, they don't use Revenue Health to enact. So it's really been, they really deserve a lot of credit for both these practices for the progress. So if you look on this left, that is work list full of thousands of claims that this payer was not paying correctly, and they're just getting denied. And imagine working through thousands of claims. Now, this is a big health center, a couple of 100,000 patient encounters a year, if not more. And imagine having that many claims on a list somewhere to work. How would you find anything else? Talk about needle in a haystack. So they put all of those in a place where they could isolate them. And what that left them with was manageable work lists such as dental, a work list such as filing limit denials. Again, if you think that's very high, some of that is payer specific. But they do a very, very high volume of claims. But then they can focus on, Medicare and Medicare Advantage. So again, the look from the left and the right, on the left, that's only one of the MCO silos they created. So you can imagine their work list screen's pretty long. So the outcome was they were able to identify significant payer issues and go back to the payer and give them, since they had all that in one place, go back and file these massive appeals with the payer, try to get things right out of the managed care. They created targeted action plans for addressing other issues, and they got some insight into their huge volumes of billing data. They're actually working more actionable claims. Their blended encounter rate, again, a couple 100,000 encounters a year, if not more, going up by 7 to 8%. So that's potential for a lot more cash for them in the door to keep working on their mission. Their denial rate, funnily enough, the denial rate went down by about the same amount that their blended encounter rate went up. So again, talking about that gap between the two. And they had a tangible increase in identified actionable claims, the things that they could actually work and get paid. So what we saw from the two case studies, in both cases, what they're reporting to us that happened inside the practice, inside the revenue cycle operation, was increased collaboration, training, communication, visibility, cash flow, and happiness, which is good. That's what we're all trying to do, is go to work, do a great job, and come home at the end of the day with more happiness about our work. And usually that's pretty well impacted by an increase or a decrease in cash flow. So both of those very, very similar stories. Different systems, different states, different parts of the country, different operations, but very similar problems. So the next steps for us in the next month or two, we'll be coming out with some AR management webinars that talk about how to decide when to work your claims. Also automating your unpaid balance distribution and identifying critical claims that have high filing limit risk or high dollar claims. Automating your tickler file. Okay, I worked this. When do I go back and work it again? And then monitoring your unpaid resolution rates. So understand the data sources and collect the information any way you can, whether it's out of your clearinghouse, your billing system, spreadsheets, whatever you can do, collect the data. If you've got access to an analytics solution such as Revenue Health, that's great. If not, we're out there. There's a lot of firms out there. We hope if you're looking for one, we might be one that you'd consider. Use the two-prong approach. Stop the bleeding and get your processes in a place where you can get ahead of your claims. Resolve denials before they become old AR, because they get more expensive and they get harder to get paid. And empower everybody with visibility. Everybody should be able to see what's going on from every angle so you can make really timely decisions about how you want to spend your day. So with that, it's just about 5 obs, and I want to be respectful of everybody's time. If you want more information, you can check us out at revenuehealthsystems.com or email us at info@revenuehealthsystems. We're also going to have some folks at the NAC P&I forum down in DC on the 27th through the 30th. So if you're interested in learning a little bit more and want to talk to somebody, contact us at the email address above. And we're happy to schedule a meeting while we're down there. And with that, I'll hand it over to Amanda. And I appreciate everybody listening and happy to answer any questions that anybody's got.
Thank you, Jeffrey. So we'll go ahead and take some questions at this time. It looks like we have one that came in. How do you take paper EOBs into account in your system?
So our system, we actually have a process which will take a scanned EOB and we can convert the scanned EOB into a HIPAA formatted A35 file. So we use a couple of different processes to lift the data off of those EOBs and put them into a standard format so that we can use them in our system. And that process takes like a day or two, but it's all automated. We pull in the scan file and kick out an A35.
Great, thanks. And looks like we have one more. Is your software compatible with all scripts?
It is, yep. We do a lot of integration. We probably have, I'm going to say, 5 or 6 different practices using all scripts. We're very familiar with all scripts, both with an external clearinghouse, or if you use all scripts connection, we know how to get to the iRemits folder and get to all the data there. So yeah, we are very, very familiar with all scripts. And when I was with PMG, I spent 5 years working on an all scripts hosted system, and PMG was hosting all scripts for a long time. So yeah, very, very familiar with all scripts.
All right, it looks like we've covered all questions. Is there anything else you want to cover before we wrap up?
No, again, I just want to, thank everybody. It's tough to cover everything we want to cover in an hour. I could talk for hours about these things, but we are definitely passionate about this. We think it's something that the FQHC and the community health community can really wrap its hands around. And, it boils down to more money coming in the door to achieve the mission you're trying to achieve in your communities. And we're behind that, and we believe in that. So, again, if you have any questions for us, feel free to contact us. If you want to link to the recording, send us an email and we'll send you a link to the recording after the fact. Otherwise, thank you very much for everybody's time.
All right, and with that, thank you all for joining us today, and we'll see you next time.